Dr. Arcella, and I want to welcome you to our first Six-Figure Therapist Masterclass. And I decided to call it a Masterclass because we have one of the masters here. And so I'm going to have him first introduce himself, and then we'll just talk about what we're going to talk about today after then. So.
Great. Thank you. I appreciate you having me here. No, I got my degree in 1983, and I've practiced clinical psychology for a long time, both in practice, and I do a great deal of teaching for different universities, including teaching supervision, and a lot of teaching in psychodynamic therapy, including brief psychodynamic therapy.
Okay. And one of the reasons why I'm so happy you're here, and I'm hoping that this will help the people who listen to this and watch this, is that I remember back in the day, we were working at a university together, and we used to get on stage and demonstrate different theories and how students can conceptualize theories and conceptualize clients using those theories. And I remember, I don't know if you remember, but that was some of the best sessions that students would come later on and say, we were so happy to be able to see the difference.
Yes.
Yeah, in the use of theory. So I'm hoping that that's something that we can do for the six-figure therapists, is to get people like you from different orientations and myself from different orientations and come together to really get people to figure out the skills that they need to do this. So first, I always say to everyone that what we do in mental health is a gift, that I think that some of the piece of this is an inner gift. And so what made you decide to go into mental health and be a psychologist?
Yeah, I think that when I was in high school, I was very interested in not only psychology, but interestingly in literature. And literature really, great novels, literature really showed me, or kind of opened my eyes, that I was really interested in character and character development and the emotional issues that the characters were dealing with. And so I thought, that's a strong interest of mine, but I also had an interest in trying to be helpful to people and helping them sort themselves out, and having my own therapy experience in high school was very helpful. And so that led me to say, I'm going to really pursue this and see if I can develop, as you say, the skills and knowledge to be able to try and do something to be helpful to people who struggled with a lot of emotional and interpersonal problems.
Okay. All right. And so once you did that, so you finished high school, you went on, of course, you got your PhD. And so then so let's talk about your theory, because, we talk about theory selection and things like that. So tell me how you selected your theory.
Yeah, I realized when I was reading in high school and college, I saw that the things people come in and talk about when they're in therapy are often relationships from the past, current relationships, sometimes the relationship with the therapist. And these relationships, they talk about patterns that have been problematic and disappointments and needs that aren't met. And I felt that the psychodynamic approach, being an in-depth kind of approach, would help me to understand the early patterns that really brought people to where they were now. And I realized that the part of what appealed to me about the psychodynamic approach is that these childhood problems that continue to affect people as adults were very much in the present. They were there in the relationship, and they were there in the room. And so when people say, well, psychodynamics are all about the past, I say to them, well, it's really very present oriented, in that we get a window into people's lives and the struggles from early development. And so it kind of provides us with a way to help people and maybe hopefully free them up from some of these patterns that they keep repeating.
Okay, so basically you saw that theory and you thought, okay, since it's about relationships, since it's about some of the earlier stages in life that's still happening today, some of those same responses and things like that are happening today, that theory best fit how you thought people, because I always try to get people to think, how do people get the way they are? And then,
Yes.
what do they need to do? So you thought that was the best way.
Yes, and also I felt that psychodynamic theory, which I think there's a lot of misunderstanding about, but psychodynamic theory, particularly modern psychodynamic theory, it really provides us with two things that I think are important in a theory. One is a kind of model of the mind, of health and problems, and it has some predictive value. Mm-hmm. It has some value in, as I come to learn about the person, I have a sense of what may be coming next. What are some of the ways that their problems may show themselves? What kind of difficulties do they get into? And so I think, you said earlier about skills and theory and case conceptualization. It's so important to be able to conceptualize with a theory in mind. And then we may learn to integrate another theory. For example, when I work with people with OCD, I will sometimes integrate psychodynamic theory and cognitive behavioral theory, including, exposure response prevention kinds of interventions. But, to get back to what you said a minute or two ago, when people in supervision ask me, well, what do I do next with the client? Which some supervisors, don't really want to hear because they want the person to think for themselves. My response, I think it's a good question. My response is, well, that depends on what you're trying to impact. And you need to have some conceptualization of what's going on. Are you trying to learn more information about something? You're trying to help them and collaborate to change behavior. You're trying to deal with some feelings. So what do we do next depends on what are we trying to accomplish.
Mm-hmm. Yeah, I call it intention. Like, what's your intention for the client, or what's your intention based on what the client has told you? And that's the thing. We'll have to do another class on that, because I was supervising somebody yesterday, for example, and one thing it was some childhood stuff with mother and stuff that, of course, is still going on, as you said earlier. And so that conceptualization of this is why it happened was there, and the client agreed with it. But then it was straight to solution. Like, so now do this instead. When you see your mother, do this. And then so that little piece in between, I don't know what that's called. I don't know if psychodynamic theory, but do you know what I'm saying? That little piece in between was what I was trying to, that it's not just, okay, because he kept going back to the big picture problem. Okay, yeah, it's your mama. Okay, right. But okay, but how do we get you to change that? Like, you see what I mean? I don't know if that makes sense.
Yeah, I think part of it is to learn how the person has internally processed what went on, and to see how maybe they also repeat that maladaptive relationship with other people in their life. And so, I tell my trainees that, everything is internally processed. If you were empathic with your client and they didn't experience it as empathy, then it was a good try. It wasn't exactly empathy. But the way I discuss it with trainees too is, if you went to the urgent care center and they said, based on what little I've asked you, I haven't really asked you a lot, here are several antibiotics, good luck, go home, see if any of them.
Exactly. That's an excellent example.
Any of them help you, and then we won't know why they did it anyway. So the other aspects of, psychodynamic theory that appeal is that, and maybe, I think this is so of human beings, regardless of your orientation, but I think psychodynamic theory really stresses this. People work really hard, consciously and probably out of their awareness, to keep things from themselves. And we hear this from people. Why would someone need to say to me in therapy, I don't have a jealous bone in my body? And as if it would be a crime to at times feel jealous, or, or I'm not at all competitive. Well, isn't there normal, healthy competition? So part of it is what people are trying to hide from themselves. And we develop these defenses or ways of hiding things from ourselves, coping, trying to preserve our self-esteem. Maybe the therapist would feel negatively towards me if they saw me as being jealous of a friend's accomplishments. Can't you feel good and maybe jealous at the same time? Which is another concept in the psychodynamic theory that people are full of ambivalences and mixed feelings. And to try and help people become aware.
Mm-hmm. Yeah, and also I'm glad you're saying those things because and hopefully we'll be able to make a bigger class about this because there was little nuances because people will come and tell me all the time, this training all these years as well. Somebody will say, oh, I'll say, what's your theoretical orientation? Oh, it's psychodynamic. Okay. What, tell me about it. Which theorist do you follow in psychodynamic? What do you mean? It's like, it's only one. No, it's more than one. and they have slightly different viewpoints about things. So, so I say that to say, can you tell me a little bit, because I know you've been around a little minute, just like me. Can you tell me a little bit about your training? Because I think that if we get back to some of our training, the way we used to be trained, maybe it might be helpful for
people. Yeah. I went through a 5-year PsyD program in clinical, and it was one of the first and freestanding PsyD programs, and it was an APA approved program, and it was an APA approved what was called a captive integrated internship. So the first 2 years had 2-day-a-week placements with patients, and the last 3 years had 3 days, and coursework throughout the whole thing, and supervision, and so. And it was associated with a hospital. So there were some courses that we did in the hospital, interviewing psychotic patients, for example. And there were a lot of therapy courses and a lot of courses on psychodiagnostic testing, cognitive, but a lot of personality testing. And there was a kind of, classical psychodynamic flavor to it. And then over time, I've become very relational or interpersonal in my psychodynamic perspective, where I see the connectedness with others and the maladaptive relationship patterns leading to a lot of symptoms such as anxiety and depression. And also I learned a lot about working with transference and being aware of countertransference. And that, it's interesting when I teach new students, they say to me, I'm going to be so aware that I will never have countertransference. And I say, well, good luck to you. And the important thing is to try to become aware of it rather than phobically avoid it, where you probably are trying not to even react. And because people are going to develop their own transferences to you based on lots of things.
Yeah, no matter.
And even, Aaron Beck, who passed away in the last few years. Yeah, Aaron Beck, who was initially trained as a psychoanalyst, had said in his later years, if you work with personality disorders, even if you work from a cognitive behavioral framework, particularly narcissistic and borderline, and you don't understand how to work with transference, good luck to you, because these people live at that level where they are putting what Freud called the transference template onto people in their life and seeing them as if they were other people from growing up. And that's why relationships with them are particularly challenging. And so defenses, transference, maladaptive patterns that people repeat. These are all important aspects of psychodynamic thought. And I think, and maybe we can get into this with other talks or classes, I think when people see that there are a lot of concepts from Freud that have stood the test of time and some that have not, and psychodynamic therapy has been pretty well researched, probably beginning in the 80s, but certainly a lot more. It may give a bit of a different perspective to this, and certainly, you know, there are different therapies that have, you know, contributed to our work with people. But I find a lot of people are very misinformed or very little informed in the psychodynamic kind of theory and therapy. I'll give you a quick example of transference. I worked with a young woman in college a long time ago. She was a grad student, actually, and the summary of it was that, you know, she grew up where her interests were more in the artistic literature area, and her father was in business and accounting, and a brother was in business and accounting, and another brother was going into business and accounting. And although her mother valued what she did, her father and brothers saw it as a, you know, a kind of cute field to go in, and really demeaned it. And she came to therapy because her boyfriend, who was in law school and doing well, while on the one hand she was proud of him, when he got an award, she became very critical of him. And so anyway, we're working together, and I'm helping her take a look at how the wish to be valued is so important, but when she feels or perceives she's not, she lashes out or gets depressed. And we're going through, I guess you could call it, either in cognitive behavioral world or psychodynamic, you know, that there's a schema that I'm helping her see. And then at the end of the session, I felt for her self-esteem. So I said to her, she asked, can we work on this together? And I said, sure. And you're a really bright young woman. I think we can work together in a number, you know, whatever, 18 sessions. And she says to me, are you being sarcastic? My calling her a bright young woman made her wonder if I was being genuine, because could I, as a male, maybe a male with a doctorate, like her dad being successful, could I see that, or did I really think her literature studies was also kind of cute? And, you know, and so I pointed out to her that we had a fascinating situation here. This came alive in the session, where a male who was older than her and had an advanced degree could not see her as smart or valuable because of the major that she chose. And it gave us the opportunity to see, well, maybe this happens elsewhere. Maybe you're assuming people are thinking this of you, and you're reacting hostily.
For maybe, you know, not when it's not their intent to do anything.
No, not their intent at all. And that's where, you know, transference sometimes comes up in how people expect the other to react to them, or convince themselves that's how the other reacted to them.
So then, okay, so with that example then, because it is interesting, because like you said, some people lash on to certain things and theories and parts of Freud's theory when they talk about, especially transference and countertransference. Everybody talks about that at some point in time, even if they say they don't subscribe to the theory. So, but for example, so in terms of skill, then you pointed that out right away. So it's two questions I would have. So first, do you kind of gauge to see if that's something you would save for later, or point out right away?
Yes. Yeah, timing and judgment are very important in clinical work. The reason I pointed out right away is because she said, are you being sarcastic? And I said, that's, what word did I use? That's amazing. And she said angrily, what's so amazing? And I said, it just happened with us. Can you think about it? And she was able to say, yeah, I thought you couldn't be genuine. And then we were able to discuss, maybe there's a part of you that is primed for this. But there are times where, yes, you you would not bring it up. And certainly we want the patient, the client, to be able to come to these understandings with our collaboration rather than us, just quote, lecturing them about it. Because people, I think in therapy, people really are looking for an experience and not just an explanation.
Exactly.
But in this case, we had it right in the room. And I was concerned if I didn't deal with it, she may not have come back because she would leave. I mean, imagine what that's like to think your therapist at the end of a session says, you're a bright young woman, and you think, wow, even he is toying with me here.
Right. And especially the part that's so interesting about the story is technically you didn't say anything that people would consider negative, right? Like you said, it's her perception of bright young woman normally doesn't make anyone be like, oh my gosh, are you serious? So
That's right. That's right. And it shows how ingrained that expectation is. And I was curious if it ever happened with her fiance, because from all accounts, he was proud of her being in master's program in literature and didn't put it down. But she could we all misinterpret it, and so and I'm not saying transference occurs all the time, but Freud purposefully tried to activate it all the time he wanted a window into the childhood relationships. And the use of the couch was partly of, I don't want to be a distraction. I want you to project onto me. Of course, he also wanted the luxury of not having to care about his facial expressions day in and day out, which can be tough. And so.
And this is that is the funniest part, because I'm writing a 6-figure therapist program, right? And I'm putting little things like that, like watch your face, show up before your client, little things like that people think, oh, that's so simplistic. But I promise you, in talking to clients, and all these years you've been doing this, those little things matter, so we do have skills, we have interpersonal stuff, but we also have customer service, we have perception, we have all these things. Like you said, it is an experience. And I always say you should be a different experience when they show up to your office. And so, yeah.
I want the people that I see to feel like all that matters in that time to me is them. And since people process how they do, people are going to read into our facial expressions, which can give us information. I remember years ago, I had a woman come back who had been away from therapy a little, and she shared that she was restricting her eating. And I was aware I had a kind of look on my face, or I reacted more with, oh, I'm sorry to hear that, that you're struggling with this. She jumped down my throat with, what's that face? What's that face? Are you feeling critical because this is what's happening with me? It just gets activated if that's their schema. And to say, well, I was aware I had a facial expression. Can you help me sort out, what made it seem critical to you? And is that familiar to you? And I wasn't aware of feeling critical, but obviously I came across that way. So is this something that, you tend to be on alert for? And those are the things, moment to moment shifts in mood in therapy may have something to do with what they think the therapist thought of them. So part of the psychodynamic approach is to try to be aware of different things going on in the room, which Freud referred to as trying to have equal hovering attention, where you don't get hung up on just one thing. And I tell my students that active listening also includes, what are we not talking about? Have we colluded together to avoid a topic because it's an uncomfortable?
So then what would you say if somebody said, well, like I had a supervisor that knew someone had experienced some trauma, didn't know all the details, but knew some, but his thing was, he said, I'm waiting till the client tells me. So like if someone thinks that, which is a logical thought process, but based on what Freud might think, would he do with something like that? Would he wait? Would he mention it?
Well, I would certainly, I think, wait in the beginning, but at some point, maybe to say, um, you know, it seems to me that maybe there are some things that you're not yet comfortable enough with me to talk about. And I put it on myself. One of the things I try to do in therapy is to be careful about the language, to do my best to try not to shame somebody. Not always easy, because a lot of people come in with a great deal of shame. But I gave a very simple example to students the other night. I said, this may sound silly to you, but I picked one of them and said, so you're my 17-year-old client. And if I asked you, tell me about your dating history, I probably could get away with that. And you probably, have dated, but let's say you haven't dated. And I ask you about your dating history. Am I inviting you to lie because I've now made it clear that I think you should have a dating history? So what I might do then is to say or ask, has the opportunity to date come up? And then you can say, it has, but I haven't. And I can say, oh, well, what do you think may, have gotten in the way of that? Or no, there haven't been opportunities. Oh, well, what has gotten in the way of that? Or they tell me about their dating. So I try not to pin someone against the wall. And even in a simple thing, because, if you say, tell me about your dating history, they may think, oh, the therapist thinks I should have had one.
And or they felt some way about not having one, and that takes them in a whole nother direction of, my friend said this, or I'm not pretty enough or handsome enough, or
right.
I can't get those ladies with me, so it could be a whole, like you said, a whole nother rabbit hole. But then this is the whole point that I hope people are getting to. And like I told you, we could talk about each of these things in depth, but the point is, the skill piece of it is, like you said, timing. It's actually, it's quickness. It's active listening, as you mentioned before. It really is. And sometimes we just think, oh, I'll just sit there and show up and it's going to happen. No, it really is a lot that goes into it. And especially if you don't have the theory to process it, then I just find that really interesting and wonder what, to be a fly on the wall, what people are talking about in the room.
Yeah. And look, it takes time for theoretical knowledge to develop. So I tell people, as we're working on this, here are other things you can listen for. Themes and patterns that get repeated are very important. And, but yeah, the skills piece, a lot of people feel, well, some people feel, the skills piece, that's not as sexy as the sitting there and trying to help somebody, understand them. But it's part of it, just like learning how to inquire to deepen the conversation. So if a trainee says to me, my client was angry with their mother, I have very little idea what that means. I mean, I have some idea, but I say, well, can you tell me, did you have a chance to inquire about the interpersonal scenario that happened there? So we know what the anger was about, and was the anger irritation? Was it rage? Was it whatever? And so without the interpersonal scenario, we don't know why. Don't know why, I was working once with a woman with dissociative identity disorder, and she, had discussed with her mother that she, her mother said she didn't know that there was abuse at the hands of the father in childhood, and the patient, wasn't so sure that the mother didn't deny this. And anyway, so they're getting along well in adulthood, but then I hear, my mother and I had a real argument about something, and I took it out on myself. And what does real argument mean? And well, what were you doing? What occurred? And I learned they're watching a television program. What was it about? What occurred? There was somebody on, some reality TV show who was discussing something in their life, and the mother said, "Oh, I don't really think that's the way it would have happened." And you can see it activated in daughter this is what I heard from her about this earlier on, until she realized how, damaged I was from this, how much I survived. So without knowing, that really couldn't have happened from a TV show. I have no idea why the irritation was there, why the disappointment and all of that. So inquiry is so important in this field, and teaching students to learn to get more data of the person.
Yeah, you know me, Scott. I call it being nosy. I always had a ghetto version of it. But yeah, I mean, you really should be I told my supervisor, there should not be a question that I should ask that you hadn't asked. So I want you to keep digging until you say, okay, Dr. Trimble should be satisfied with this. Because like you said, if you only get a little bit, you're making assumptions about what it is, and you're just throwing out random stuff, when in fact, most people, if we're asking questions at the same level as everyone else, because most people don't listen well, most people don't ask a lot of questions, then we're not doing our jobs as much. So I'm gonna go back though for two things. One, when I was asking you about your training, did they watch you? Because I have found when I've been training supervisors that supervisors don't have people who have actually watched them do therapy.
Yeah. Well, I kind of predated the video.
Live? Did they watch it live or?
On occasion,
okay,
if they were in the same agency or clinic. But what I did do is, and this was tedious as anything, is I would, for certain supervisors, transcribe sessions from a tape recorder.
Okay.
And I tell my younger students, you can Google what a tape recorder is, and so I would read verbatim, or we'd listen to it verbatim.
Okay.
And so yes, and there were process notes, but there were also the recordings of this. And when I supervise or teach, I do watch videos with the students because, it's an interesting role as a supervisor. You're talking with one person about another who you've never met. And so I'm trying to understand the person through the eyes of the trainee, but I also want to see how their own issues or distortions are impacting this, or their own reactions. And if they're irritated with a patient, what has activated this in them? And, I was dealing with a new student who, was pretty new to this and was doing a CBT treatment and used homework as a part of it, which is, part of that. And the client would say, yeah, sure, I'll do it, and then hardly do it. And the trainee was so irritated, was saying to me, I think they're doing this to get back at me. I'm like, would you come to that? Well, it made them feel incompetent.
Oh, okay.
And just like new trainees who we don't even expect to know much, the word they use in sessions with me is that they feel like an imposter. I'm like, who do you think you're impostoring?
Yeah, you have to have somebody to.
I mean, but anyway, so to help them understand what is going on between you and the person, that you're in this interpersonal loop where you give them homework, they say yes, and they don't do it. This needs to be understood rather than your irritation about it.
Yeah, and we can talk about supervision again too, because we had supervisors who said if we gave that scenario, sometimes they'll say something like, well, maybe they need to go talk to somebody else. Well, no, you have to talk to them at some point, because guess what? They still might see that client next week. And even if they did go to therapy for whatever issue it is, you still have to do something to help the client, so you can't just say,
Yeah, I mean, one could consider asking the client, if something gets in the way of you doing it, did you feel able to tell me that you didn't want to?
Mhm.
But that can be anxiety provoking for trainees, because
Right.
we're asking them now to get into process
Mhm.
what's occurring between the two of them.
Mhm.
And I tell students, as one of my mentors years ago used to say, while psychotherapy is complicated, at any given moment, there are three things we can choose to focus on in the room: the content of what they're saying, the affect or emotion they're having, or the process of what's going on between the two of us, if it's relevant to them.
Mhm.
And so process is an unnerving topic. You mean you want me to bring up something between you, me, and them? um, and so yeah, the supervision helps people to learn about that we're not just an observer; we're a participant observer in that relationship.
Yeah, and then the second thing I was going to ask you, when that example that you gave about the transference with that client, so you were saying, okay, so it happened in the room, we see it live. So how would you, and you kind of talked about some of the things you might say, but how would you get her, you said if it shows up in other relationships, for example, the fiance and things like that, what was that little piece that I keep talking about in between that you could say, you could do something with that as opposed to
Yeah.
just saying it?
Yeah, one way to inquire about it is, what just occurred here? Is this familiar to you?
Okay.
Is it something you've seen before? Um, and you're inviting them to be curious about, do I bring this to other relationships too? Yes, there are people who are critical in life, but am I gunning for this and will prematurely decide that somebody is critical of me? And then one can also discuss, well, what are some of your thoughts about where this might have come from?
Mm.
And you're inviting them to think about the important people in their life. So you were asking about, kind of how do you help a person to see if the transference is occurring elsewhere at times. And one way would be to ask, is this familiar to you? And for them to think about maybe other relationships, and then maybe to inquire, is this something that you feel maybe important people in your life have contributed to, and they might think about where this comes from. And one misconception that people sometimes think is that transference is always about parents. It can be about siblings. It can be about other important people as they grow up, who they, and how they feel those people felt towards them or reacted towards them. Um, so, um, yeah, it's trying to get the person curious about these interpersonal patterns, and do they occur elsewhere, and do they contribute to the depression, anxiety, and other symptoms that they have.
So then if they say, yes, it does, I saw it with my fiance, I see it with my friends, that kind of thing, then how do you help them to change it?
Yeah, what we try to do there is to see, well, first, being more aware of it helps. Just like I would equate that to if you're doing cognitive work, and there are cognitive aspects of psychodynamic work. If you're helping somebody with a quote cognitive distortion, you want them to become more aware of it. Mm-hmm. And not to immediately act on it, to put the brakes on, so to speak. But also, I think part of the psychodynamic interpersonal approach is to help them consider how they're trying to get their needs met, and maybe they're doing it in ways that are evoking these reactions from people. Mm-hmm. And so they're recreating a pattern. Okay. So to look for healthier ways, not that we always get needs met, but to look for healthier ways to try and get them met. Okay. That makes sense. Or as I tell people, if you quote those scholars the Rolling Stones. We don't always get what we want, but if we try sometimes, we get what we need. So that occurs in relationships too.
Okay. And so then in thinking about the psychodynamic approach, what can you tell just people who might be interested in it? Because again, we all have heard of Freud, for example, but like, could you tell them, I guess, first of all, the basic outline, like you talk about, you do brief therapy generally, right?
Yeah, because I'm focusing on relational patterns, but if you're interested in, people are interested in the psychodynamic approach, concepts like learning about the unconscious, is important. I mean, how many times have we heard people say, I did X, but I don't know why? Mm-hmm. Learn about the unconscious, defenses, transference, mixed emotions or ambivalences. The thing that's used in the literature to turn people off the most to psychodynamic theory is the concept of penis envy. Mm-hmm. And Freud was biologically based in his thinking. Mm-hmm. So he attributed a lot of the envy that his women patients had to anatomy. But, he saw something. But we've come to see, that he saw something correctly, but it really had to do with what people over the years have called social envy, status envy, opportunity envy, where the times he practiced, women were really discouraged from getting education and opportunities. And so there was a lot of anger and frustration from his women patients about male siblings and men, and I'm not saying that discrimination, oppression, things don't occur now, but he saw something, but he didn't see it as the sociocultural phenomenon that psychodynamic thought has come to generally see it.
Okay. And so I guess as you think about that, then how, if somebody wanted to start, well, no, first, let me go back. So some of the most common problems we see or issues that people come to therapy for are depression and anxiety. So can you just talk briefly about how, from a psychodynamic perspective, you view depression and anxiety, or how you would treat that?
Yeah. I mean, I don't want to assume everybody's going to fall into a same box, so to speak, but for depression and anxiety, I look at things like, are there interpersonal needs that are not getting met that are contributing to them? Mm-hmm. Are there maladaptive patterns that are repeating and the person's responding to unmet needs and feeling not valued and dejected, for example, with anxiety, depression? Are they hard on themselves? Are they, have they kind of taken in the critical beliefs of people from their growing up, and now they're very hard on themselves, and that might be creating depression because there's an underlying perfectionism that they can just never meet. So I'm looking both internally for what's going on within them and how they feel that, about how they're doing in life, as well as the quality and the nature of their relationships. And then I get to see how they relate to me. Mm-hmm. And that gives me additional information. You probably have had the same experience as a therapist over years. At times I have been credited with things I never said exactly the way they heard, or blamed for things that I never said in a certain way. And maybe there's a parallel between that and parenting, yeah. So I would say anybody who's interested in this should really get education about psychodynamic thinking and how we conceptualize. And then there's a lot of stuff we can't get into today that I use. The use of dreams with some people when they're open to that. So I think, my hope is that in listening to this, some people might get a little interested in learning more about the theory and the techniques and other ways to try to understand human behavior.
Mm-hmm. So then are there any books you would recommend or anything you would recommend them listen to that you can think of, like off the top of your head? So many.
Yeah, there's a lot of stuff. I would, I can compile some references for you.
Yeah, we can add that to it. Yeah, that'd be great.
And videos. I have a video out there in YouTube land from a school I teach for, and they put it out there on brief psychodynamic therapy. And I'll give you that link as well. I mean, it's, people can take a look at that. And there's a lot of interesting stuff that I hope, kind of this has whetted the appetite a little bit.
Mm-hmm. And then are you still doing supervision for individuals who are interested, or you doing that as well?
I have. At the moment, most of my time is with teaching and mentoring. I teach for 2 universities, and I have a psychodynamic study group for graduates who have interest in psychodynamic theory, and we meet monthly and go through articles. So yeah, most of my time is right now with teaching.
Okay, so maybe we can, if you ever have anybody join the group or something, maybe we can put something in there about the group so that they can know about that as well. I guess the other thing that I just want to say is thank you, first of all, for doing
Sure.
this. And I'm hoping, like you said, that people will be interested, because a lot of times people say they're looking at all the different theories and they pulled out different things. But again, just being intentional about doing it. So hopefully people will be more curious, so that when they do that, they have more informed information about it.
Yeah, that would be great. And also I'll try and put on that list some work of some colleagues that have really looked at the research efficacy of psychodynamic therapy. And so people can see that, that there is a scholarly approach to this as well.
And also, I'll tell you one experience I had with you before we go. I remember you and I were doing a role play years ago. I don't know if you remember this, in front of some students in a class. We were in some kind of conference room, and we had a bunch of students there, and we were doing a role play. And I think that I was a therapist at the time. And I don't know if somebody else was a client and you were watching me or something. I don't remember how it was going, but I remember that I said something about the person being angry. And you said to me, well, how do you know they're angry? They didn't use that word, use the word that the person gave you. And to this day, I still remember. So it was a small thing, but it was like, yeah, I projected that word onto them, when in fact, like you said, they didn't say it. I just put all that together and came up with that word. And so I still teach I still remember that to this day. And so I'm hoping, even though that may seem small to some people, that does, if you keep doing that to a client, right, over time, and I don't want to start back the conversation, but the point I guess I want to say is, hopefully when people hear things like that, they're able to incorporate them. So I'm hoping that this type of class and training will help people to just get those little tidbits like that, so that they can just, do even better to help people.
Sure. Well, thank you. It's been a pleasure to chat with you about all this.
Yay, thank you. And I know you'll be back, so I appreciate you.
All right. Thank you. All right. Take care.